So, welcome everybody. If I could ask you to take your seats, we're about to start the Terumo Symposium. Over the next 30 minutes or so, we will have some very exciting data. So we're going to have some late-breaking data, in fact, from the Terumo Nagomi Complex PCI study. This was a 3,000 patient analysis of patients undergoing PCI for complex PCI indications. So this is the largest such analysis in the literature. And we're going to present for the first time the bifurcation subgroup analysis. And what better person to present it than Goran Stankovic? So Goran, over to you. The stage is yours.
Thank you so much. And also, of course, thanks to Terumo for sharing for the first time data. We are really thrilled to understand how updated treatment strategies plus new device platform will impact clinical outcome in complex bifurcations. So this is the flow chart of the symposium. And I'm part of the steering committee with Mamas. And we work really hard to get the most valuable scientific information from the Nagomi Complex Study. As Mama said, it's a 3,000 complex PCI patients. Study enrollment is completed in 13 countries, in 52 sites. And these are the subsets that we decided to focus on. According to the literature, it's left main, it's complex bifurcation, chronic total occlusion, in-stent restenosis, severe calcification, long stent length, more than 60, and multi-vessel PCI. So all patients are actually stratified by the special focus on high bleeding risk patients and bifurcation lesion. All patients with bifurcation lesions will have independent core lab QCA by the CIRC. So definition of complex bifurcation in this study is traditional one. So complex bifurcation defined as true bifurcation 111, 101, 011 with side branch diameter more than 2.5 plus at least one of the following. Side branch disease more than 10 millimeters, presence of calcium or thrombus, and or plan upfront two-stent strategy. Why we focus on these specific lesions? Because they are known to be associated with high event rates, restenosis, MI, stent thrombosis. In Excel and Stintax, these patients are underrepresented. And of course, it's operator-dependent strategy, which determines also variability in the outcome. Nagomi Complex offers, as Mama said, the real-world data on the strategy, technique, and outcomes in this high-risk subset. These are baseline characteristics. This is the data from the mid-2025, so approximately 2,800 patients were included in this preliminary analysis. In that subset, 380 patients had at least one complex bifurcation lesion according to criteria that we commented, and the rest is total population without those complex characteristics. Approximately 70 years old, 20% female, expected percentage of traditional risk factors for coronary artery disease. What was important, almost 50%, 47% in the complex bifurcation subset were also high bleeding risk. And I think it's very important because you combine two different high-risk criteria for PCI. Clinical indication in 2/3 of patients was chronic coronary syndrome, 1/3 acute, and out of that, majority were actually non-STEMI with only 10% of STEMI. This is something that we are really proud. 82% traditional radial access, approximately 2 lesions identified, 2 stents used on average. Left main stenting comprised huge proportion, 42%, and imaging 47.6%. So I really believe that this reflects the most contemporary not only strategies, but also image guidance, especially for complex bifurcations. And if you see distribution according to vessel, it's majority half in the LAD diagonal, and as I said, 40% in the left main. Medina classification, true bifurcations 1, 1, 1, 3 out of 4 had 1, 1, 1, and the rest was the other subsets. These are the procedural techniques that we would like to share with you, and we are very proud. You remember data from some previous presentations today. POT was used in almost 83% of patients, re-POT 40%, final kissing 61%, two-stent strategy 53% in this complex bifurcation subset, and as I said, 48% intracoronary imaging. Just as a comparison, this is from recent publication in the Ultimaster study. We published that with Bernard Chevalier in neurointervention, and it's relatively recent, 2021, and you see POT 33%, re-POT not applicable at that time, final kissing 36%, in overall bifurcation population, of course, not in complex, two-stent strategy 25%, and imaging only slightly below 10%. So I think that we can see huge progress in developing better procedural technique to optimize the result and the integration of imaging in almost half of the patients. When we speak about two-stent strategies, it was predominantly culotte, then crush, then T and tap. On average, it's expected 20% crush, 30% culotte, and 30% combined T-stenting and tap stenting. QCA analysis, we have many more data to share later on, but this is just preliminary reference diameter. Main branch large, 3.8, side branch close to 3 millimeters, so expected according to inclusion criteria. And now we come to clinical outcomes. So we have data for 30 days, and we have data for 6 months in this subset. So first data for non-complex bifurcations, which means total population, and you see target lesion failure combination of cardiovascular death, target vessel MI, and target lesion revascularization at 30 days, 1.5%. In complex bifurcations, significantly higher, 3.5%, predominantly because of, as you may see, higher rate percentage of target vessel MI, low rate and similar of cardiovascular death, TLR, and stent thrombosis, only 0.3%. At 6 months of follow-up, in total population, non-complex bifurcation, cumulative TLR 4.2%, and in complex bifurcations above 6%. Still very low considering the complexity of patients and considering that half of those patients are also high bleeding risk, having left main or complex bifurcation. Again, we see the difference predominantly because of difference in target vessel MI, and the 4.5% versus 2.3% also reach statistical significance. Again, there is no difference in mortality, no difference in repeat revascularization, no difference in stent thrombosis, but very low rates of stent thrombosis in complex bifurcations, as you may see, only 0.4%. Now, single stenting versus two-stent strategy, we already saw data from Korea. In single stent, very low rate, 5.5, statistically significantly higher rate with two-stent strategy, no difference in mortality, no difference in target vessel MI, although there is a numerically trend, and very low rate and no difference in TLR and stent thrombosis. If we go to 6 months, then we attain statistical significance, 9% in two-stent strategy compared to 3% in provisional, with non-significant difference in any of categories of the primary endpoint. Finally, sub-analysis compared to high bleeding risk and complex bifurcation versus no high bleeding risk, 3% versus 2% in 30 days, 4% and again 7.5%, predominantly combination in this case, target vessel MI, slightly higher difference in cardiovascular mortality without statistically significant difference. So I would like to conclude that in true bifurcations, they present challenging anatomical and procedural lesion subset, often is excluded for major trials, despite, as you may see, important clinical relevance. Complex bifurcation PCI carries higher early risk, especially if we use two-stent strategy in complex bifurcations, highlighting the need of optimization technique and tailored follow-up. And Nagomi delivers favorable outcome in complex bifurcation with consistently low cumulative target lesion failure and 30 days, persists at 6 months, even in high-risk PCI and high bleeding risk patients. Thank you very much for your attention. Primary endpoint is expected next year.
So thank you, Goran. We've got a couple of minutes perhaps to discuss. I've got Peep Laanmets here as well, so welcome, Peeps. I mean, this is remarkable data. 50% high bleeding risk. And I guess from your perspective, it's really nice to see such a change in practice over 4 years.
Absolutely. I'm so glad, to be honest, to see 82% POT. Because what we learned in these 20 years of EBC is that proximal optimization clearly impacts on clinical outcome in absolutely every sub-analysis. And I believe that this shift towards stent optimization after main vessel stenting is, I think, key to achieve this good clinical outcome.
I mean, so we've seen about half of the patients have high bleeding risk. And of course, we know complex bifurcations are amongst the highest ischemic risk patients. Maybe I can ask for a show of hands in the audience. I mean, what are people doing? I mean, you've got complex PCI on the one hand that, you know, suggests high ischemic risk versus high bleeding risk. I mean, who's using long DAPT in these patients for the bifurcations with 2 stents? Put your hands up. About short DAPT. I mean, we've got data from Master DAPT. Is everyone happy for 1 month DAPT for 2 stents? Everybody else doesn't know. We've had 3 respondents. What are you doing? What are you guys doing? Maybe Goran then.
Yeah, so 1 to 3 months, depending on the balance between ischemic and high bleeding risk, trying to make it as short as possible. But of course, I believe that this kind of 50% image guidance, 80% POT, 60% kissing really ensures maximal effort to optimize procedural results.
Yeah, go ahead.
We do in those patients with very high bleeding risk is that we give triple therapy for a week, and then they get either if they have another bleeding risk, then they just get clopidogrel as a.
So triple therapy, you use anticoagulant.
Oh, if they have atrial fibrillation, a very high risk.
So, Mamas, I mean, I wonder whether part of the lack of response to your poll is due to it kind of reflects the complexity of the situation. Yes. And I think probably the greatest concern is actually a failure to identify the high bleeding risk. It's very easy to identify age as a marker or the use of an anticoagulant in combination with antiplatelet therapy, but we know that the most potent drivers can be more subtle. I mean, taking the history from a patient in terms of prior bleeding or being borderline anemic are probably the most potent drivers. And so really it's a call to arms. You've managed to get POT from 30 to 80%, but perhaps we should be undertaking more formal bleeding risk assessments in patients prior to the prescription of highly potent antiplatelet.
Yeah, I mean, I think that the important thing is that we've got now several means of quantifying objectively the balance of ischemic versus bleeding risk. So, for example, the HBR trade-off model, the precise HBR model, and when you look at data derived from them, the so-called high bleeding risk patients, between 30 and 50% of them would benefit from more prolonged DAPT. So I think that's a good point.
Mamas,
Yep.
that one of the things that you have not talked about is DAPT or SAPT, okay?
Yes.
So I think it's very important to differentiate, because in recent ACS guidelines, you're very clear that for the first month, you give both aspirin and clopidogrel, and after that, you can drop it down to either aspirin or clopidogrel. I think DAPT as such is not there. I mean, I think we can do that part.
Yeah.
But I think clopidogrel should be the preferred agent, you know. And
I mean, the other thing that people don't, platforms have all evolved, and we automatically assume that all platforms will behave the same, but they don't. I mean, I think one in these sorts of cases has to use a platform that has been validated in high bleeding risk cases, and not all of them have. So there are maybe 3, possibly 4 platforms that have had randomized controlled trials in true HBR cases, but many of the platforms that we're using in the cath lab haven't. And so I think that's another area that we need to consider. Maybe I can...
just comment, one more comment. We also use like 1 to 3 months of antiplatelet treatment, depending on the patients. But one comment I wanted to make was, if you have a high bleeding risk patients, it's very important to do a good job in PCI. Use an imaging. I think this is the most important thing. Just if you can identify the high bleeding risk patients before the PCI, just imaging is mandatory. Just I think if you do good imaging, I would feel quite comfortable with 1 month of depth.
So Peep, now you've told us about doing good imaging, good cases. Let's see the cases. So over to you to show us 2 cases with the Nagomi platform that you've undertaken in complex bifurcations.
Hello everybody, my name is Peep Laanmets. I'm coming from Tallinn, from Estonia. Wow, I feel really tall here now. Okay, so I was investigator. We were involved in a Nagomi Complex trial. We did quite a lot of patients in the trial, like 10% actually. We have been using Nagomi stents for quite a long time. I think our center was the first in Europe actually to start using it. History has been there for like 2.5, 3 years, maybe even. So, I like stents, let's say. And yesterday and today also, we have been talking a lot about DCBs, and also in our center, the DCB growth is growing really exponentially. So, and I have also been evolving. So since we started the Nagomi trial, we have done 2 turns around sun already. So time is flying. So okay, I will talk about basically Nagomi stent's behavior in complex PCI setting. So what are like the special characteristics in Nagomi stents? So I have to say that this is one of our centers now most used stents, because it's very you can taper it very well to the vessel wall, to the different sizes of the vessel in different parts of the coronary anatomy. So it's very conformable. Okay, I will do two quick cases. One, first two being a 71-year-old male with unstable angina and normal ejection fraction. It's good so far. So the right coronary had been actually stented a couple of months ago already. So this, I will not show the pictures, but the right coronary is good. So this is like it was more or less planned, but he came before he was supposed to come because of the new troponin leak. And this is a left coronary artery. So as you can appreciate, there's a quite severe stenosis in the left main. Well, there's a quite lot of disease in LAD in mid part. One small diagonal also, which is well, definitely stenotic, and there's not anything special in circumflex. Circumflex is not not too big, but let's say medium size. So, of course, we do a lot of imaging, at least in complex cases. All left mains, basically 100% of left mains should be done using imaging in our center. But OCT catheter actually, well, this is a, okay, let's start from the beginning. This is our first pre-dilatations. As you can see, there is a dent on it, and OCT catheter actually didn't go through without any pre-dilatation, so this was actually the need for the so aggressive pre-dilatation before. There was a lot of pre-dilatation, so I'm skipping a lot of imaging here. So finally, the OCT catheter was in place, actually using the catheter extension there. And this is the OCT images of this patient. So as you can see, there's a lot of calcium in the distal part, middle part of the LAD. Proximal LAD is quite large. It's actually, I don't know, can you say it's like aneurysmatic, or it's more than 6 millimeters, 6.5 actually in some places. Also, the left main is 5.5, 6 millimeters. And the left main stenosis is also quite severe and calcific. So this is a beginning of the procedure now, basically after the pre-dilatations. So we did, as you can see, there is a lot of calcium. We did a lot of pre-dilatations. Non-compliant balloons had a dent on it. So this is a 3.5 shock wave. We were able to deliver 20 impulses, and then actually the balloon broke, as you can see here. Yeah. So the shock wave broke after 20 pulses. But it did its job. So after that, we did some cutting balloons, which is also quite widely used in our center. So a lot of cutting balloons, non-compliant balloons, and then finally we got to the stent delivery. So here is a 3528 Nagomi stent being delivered to the distal part. And after that, shorter, not too short, but 28 millimeters. I just wanted to show here that we are not trying to nail the ostium of the left main, but just to cover the lesion, cover the stenosis there. So. And here it is, 4528 Nagomi stent. Talking specifically about Nagomi stent, this is 4.5, but you could actually, well, if the LED would be quite small, not to comply with 4.5 stent, you could use 4.0 or 3.5 here actually, because even a 3.5 Nagomi stent will go up to 6.25. So you can actually post-dilate the 3.5 stent to more than 2.5 millimeters. And this is OCT after this stent delivery. Well, angiographically, not too bad, right? But as you can expect, we did OCT, and this is OCT. So definitely we had to do some more work there. So this is now the 6.0 non-compliant balloon. We did, actually the distal part was also post-dilated a lot, but skipping that. Just showing the most important part. So 6.0 NC balloons in the proximal part of LED and the left main. And then final OCT also here. And this is OCT result now. So just showing the importance of imaging in the left main and PCI overall, actually. Angiographically, it looked quite good. So now the problem is fixed. Anybody, just show of hands quick, who would do left main kissing in this patient after this work here?
Okay, so 3 or 4 hands. Who wouldn't do it?
Not so bad actually. Okay, we are getting people involved now.
Yes, I'd say most wouldn't. Well, most don't know, but
well, let's say 50% would do kiss. But we did not. But I left that as it was. But it was one thing we also thought about a little bit. But as we had done quite a lot of job there already, and and didn't actually want to have a circumflex PCI.
Got 2 minutes for this
Yeah,
case.
actually, okay. So let's go quickly to the second case. So, let's call it Friday evening case. 60-year-old man with non-STEMI, good ejection fraction, but we knew that the patient had already refused CABG for multiple times. So we knew that the patient had 3-vessel disease. This is a right coronary that was occluded before, so this is nothing new. This is CTO, a short one, but still. And left main was the culprit. We didn't actually know where the culprit is because it's quite severe and diffuse disease everywhere. Left main, well, maybe 50% stenosis, let's say, definitely stenosis in circumflex ostium, all the way to the, well, quite a long lesion, let's say. Posterior lateral branch also involved, and the LAD mid part is severely calcific and stenotic. So just a quick, what would be your preferred stenting technique in this case? Culotte, T, tap, or crush? Or does it really matter?
So hands for culotte, hands for T-stent, hands for crush.
Okay.
So I think
crush would be the most liked here. Okay.
Probably 5 people for crush, everybody else don't know. Okay.
I guess actually, my plan was to do a T or tap here, but well, this was our initial plan, but plan is always, plan evolves. So you do the start with PCI, with ballooning. Well, balloon is there, NC balloon, 3.0. Well, did something because I got the shockwave balloon through, and shockwave actually cracked the calcium there. Retrospect, I would have done the rotor there, but not in this case. So OCT. Let's go forward. So skipping a lot of ballooning there. Anyway, LED was ballooned, cutting ballooned, everything, shockwaved. Now showing the circumflex ballooning here, a lot of balloonings of also, and this is now the stent, 275/50 actually, into the circ. And this was the first. In retrospect now, anticipating all the questions about why not DCB. Yeah. And this is second 50 millimeter stent in from LED, from left main ostium to LED also there. So there you go. Yeah. Okay. And well, a lot of post-dilatations, and this is a final kissing there. So. Well, it looked good. So anyway, we did OCT, skipping the OCT here. This is just final angio image here. And we actually had the patient back like 9 months. No, this is 1 month after that we did the right coronary also. So I just skip here. Antegrade approach, distal stent and proximal stent. So 2 stents, 10 centimeters of stent there also. Oh, I know. Now I would do the 1 stent and TCB. I have to say beforehand already here. So, okay, this is an initial final result. And patients then came back 9 months later with some chest pain, but like a stable, nothing. Troponin was good. There is some little bit of wrist stenosis in ostial circ, but FFR was good, so we didn't touch that. LED is totally good, and right is as it was. This is a case. Okay, and thank you.
So you guys definitely like stents. So open for questions. 1 or 2 quick questions.
I mean, just to reinforce the importance of the imaging, it's a lovely first case with the use of the OCT, but the question that was asked about would you kiss or not, I would urge that you use the OCT to provide some guidance in that decision making. So if actually you find that there's lots of stent across the ostium of the circumflex, then that may well be a rationale for wanting to clear the stent, or in the polygon significant malapposition, then that may be optimized by the kissing. So you had information available that perhaps wasn't fully used in the situation.
Any other comments before we close off? No? Well, one more comment. Last question, then we'll close off.
Yeah, I do have one more comment. I think the first case is a perfect example for the use of CT, which we do very commonly in our practice. it was a huge effort, I think, to get the imaging catheter down there, the LID. And if you would have had a CT, you would have seen what's the issue, the calcification. You would have gone in the procedure with a plan, with a clear plan. So we really appreciate the use of CT, I think, in those cases.
So I think with that, I'd like to close off. I think this has been a great symposium. We've seen that patients with complex bifurcations are a significant part of our workload. Half of them have high bleeding risk features. We've seen that the 30-day and 6-month outcomes are very favorable, actually, with this platform. And we've seen, maybe largely through your efforts, a real evolution of practice, certainly from the Ultimaster registry, which many of the same operators worked in, to the newest Nagomi registry. And I think the final thing to say is that I think the levels of target lesion failure and event rates in the HBR population were actually a lot lower than I thought they would be. And I think that's testament to the platform, which is the first platform to have a CE mark for HBR cases. So bear that in mind when you're doing these sorts of cases. So with that, I'd like to thank Terumo for sponsoring this session, and to everybody in the audience who stayed and who recruited for this study. Over to you, Goran.
Thank you. I just would like to say thank you to all of you, because this is the same group of people in the last 20 years discussing the topic, improving the strategies and technique, and now we see really the result, which is absolutely amazing transformation in a just 5-year period during the recruitment in Nagomi Complex, and I'm really so proud to have the opportunity to share this data. Now, coffee break, and we re-adjourn at 5.